So welcome everyone to our series. Our team is grateful you're here. Of course, seeing you in person would be perfect, but given the ongoing response to managing the SARS-CoV-2 pandemic at Hopkins and also in our local communities, we've decided to continue using these virtual platforms. They've proven to be an efficient use of information, education, discussion. A couple of updates. You'll find our updated program and a new newsletter on the web. Just Google Greenberg Bladder Cancer Institute. Next month, October 12th, we will be turning our platform over to the amazing upper tract urothelial cancers team for an engaging look at their new multidisciplinary clinical practice in action. And I wanted to again draw your attention to our evolving group of programs specifically tailored around the experiences of women with bladder cancer, developed and led by Drs. Armin Smith, Jeannie Hoffman-Sensis, and the program team of Pamela Getz, Samantha Rockler, and Stephanie Cooper-Greenberg. Their next program is in December and will be a conversation of life with and after bladder cancer with a much respected panel. Their programming is also on our website. And of course, please reach out and we can send you the details specifically. Again, all of these are up on our website. And if we can help you directly, we are only an email away at bladdercancer@jhmi.edu. Again, I'm grateful to all of you for joining us today for a conversation with Ken Brothers and our own Dr. Noah Hahn. I hope you'll allow me a chance to provide a few brief introductions. So Ken is a retired patent attorney and the creator of Ken's Cancer blog. I think many of you may be familiar with it. Many of us in the bladder cancer community lean on Ken for that important patient-based insight. He serves our community as a patient advocate, along with Stephanie Greenberg, on the National Cancer Institute's Bladder Cancer Task Force, very important body. In addition, Ken has participated in clinical research since 2012 and has been enrolled in multiple clinical trials. And for the purposes of our discussion today, I'm grateful that his oncologist, Dr. Noah Hahn, is joining us as well. Dr. Noah Hahn is a medical oncologist who has dedicated his career to helping bladder cancer patients. He is professor of oncology and urology and serves alongside me as the deputy director of the Greenberg Bladder Cancer Institute. He received his MD from Indiana University School of Medicine. He completed his residency in internal medicine at Duke University School of Medicine and performed a fellowship in medical oncology at Indiana University School of Medicine. Noah joined the Johns Hopkins faculty in 2014. Prior to that, he was the director of GU Medical Oncology at Indiana University and chief scientific officer for the Huger Oncology Group, a cancer research organization that evaluates innovative and promising approaches to cancer treatment. Parenthetically, they're now called the Huger Cancer Research Network, and Noah and I serve on the core clinical science, correlative sciences community, along with Trinity Bevilacqua, a new member of the committee. Noah is currently conducting clinical trials to test new therapies for bladder cancer, including those for early stage bladder cancer. And like Ken, he also serves our community as a member of the National Cancer Institute's Bladder Cancer Task Force. In addition to that, he's chair of the Bladder Cancer Subcommittee of the Eastern Cooperative Oncology Group, ECOG. Gentlemen, welcome and thank you for joining us today. Noah and Ken have agreed to speak for about 25 to 30 minutes around the topic of clinical trials, and then we'll transition to a larger group discussion. If you'd please write your questions in the chat, we'll use them as talking points during the group discussion. Noah, Ken, I turn it over to you.
All right. Well, thank you, David, and thanks for having us. As this month's discussion. As David had mentioned, Ken and myself are going to spend about 25-30 minutes here just kind of covering some different aspects of clinical trials, perspectives from patients, physician standpoint of ourselves having been part of that, but also, different things as far as designs, experiences, and really helping to provide some information to you, the audience, on some changes in clinical trials over the years, and also try to debunk some of the myths and mythology about it. So Ken, I thought maybe we should start with some brief introductions. Again, many of the folks on the community know us pretty well, but I'll just go myself real quick, and then I'd like you to kind of speak a little bit about your own particular journey. As David had mentioned, I'm a medical oncologist on staff here at Johns Hopkins, and I've been involved in clinical trials throughout my entire career, both the design of them, the conduct of them, for my patients, in a personal level for even some family members at different time points. It's the bread and butter of what I do every day, but I think what I really, really enjoy about clinical trials is being able to talk to patients and their families about different options for their care. We're making a lot of progress in bladder cancer, but we definitely need to do more. And I think clinical trials is one of the avenues by which we see that. So Ken, maybe if you could kind of just again real briefly for the audience who have not met you yet, just tell us a little bit about your bladder cancer journey and how your experiences in clinical trials have taken place over the years, because this has been an evolving sort of story.
Thanks, Neil. I was diagnosed in November 2011 at age 49 when I had blood in my urine, and cytology suggested I had bladder cancer. So I had two different transurethral or bisections of my tumor to stage me eventually at T2B, deeply muscle invasive. And it was micropapillary variant, which is one of the more aggressive versions of bladder cancer. And the debate was whether I go straight into a radical cystectomy or whether I try to have some sort of chemotherapy, neoadjuvant chemotherapy. Back in early 2012, immunotherapy was not an option. And so the consensus was, after consulting with several doctors, that I should have neoadjuvant chemotherapy. So I started that in January of 2012, went through 3 rounds of GemCis chemo. By the way, my baseline CT scan was negative in December of 2011. Had a second scan in April of 2012, which showed that I had nodal Mets involvement. So we hit the brakes on chemo and decided to have an immediate radical cystectomy. I was supposed to have that in late June at Hopkins with Mark Schoenberg, but as it turned out, the Hopkins ORs were being renovated and I couldn't get an earlier date. So Mark referred me over to Gary Steinberg in Chicago. I gave him a call, and that was on a Friday, and he said, well, I just had cancellation on Tuesday, get on out here. So I flew out there and had radical cystectomy at on 2 days notice in Chicago. And that the pathology found that I had 12 nodes on my right side involved. It was a deeply invasive upstage to T3, and with the nodal involvement, it was stage 4. And that's when Gary suggested I try my first clinical trial. It was a Dendreon trial, and I was randomized into the control group. And so that's how I met Betsy Plimick up at Fox Chase, because she became my contact. Every 3 months I went up for CT scans and entered watchful waiting to see what my cancer was going to do. And that lasted for about 1.5 years till my Mets reasserted themselves. And so here I am in late 2013 figuring out what to do. And after consulting, again, by this time my group of oncologists had grown to about 8, and the vote was 5-3 to go ahead with more chemo. So I had dense dose MVAC, which I do not recommend to anybody. It hurt to blink my eyes, but it succeeded in slowing the tumor growth, which was the whole name of the game, because my doctors knew that perhaps immunotherapy was coming down the pipeline. In late 2014, I was evaluated for another clinical trial through NIH, and that happened to find I had pulmonary embolisms in both lungs. So I was ineligible for the trial, but started with low molecular weight heparins to work on that. I found out I was allergic to Lovenox. I had an impressive rash all over. But went on Xarelto and figured out, and that succeeded in slowing the pulmonary embolisms. And meanwhile, Andrea Apollo at NIH contacted Noah and said, hey, can you work this guy into the nivolumab clinical trial? And I think I was one of your first patients.
Yep, it was early. Yeah.
But soon after you came to Hopkins, and I showed up in early January 2015, and he said, yeah, well, let's see what we can do, and got approved. And so I started taking nivolumab every other week, and was one of those rare people that had a complete response, no evidence of disease after 6 rounds. So we continued that on for a couple of years until we figured, well, we're at the end of the trial, now what? So we did more watchful waiting, and a couple of years later, the Mets reasserted themselves. I went back on nivolumab. Took a little bit longer to get them to retreat that way. And I had a persistent node of tumor up here at the bottom of my neck. So we treated that with radiation. So I've had, I guess, the trifecta of treatments. I am now back on watchful waiting. And, last month, I found out I had more pulmonary embolisms, as well as having a frozen vocal cord nerve, probably due to the radiation, the bottom of my neck. So, hey, but no Mets. So, and I continue to serve on the NCI's bladder cancer task force. So I get to collect ways of what my next treatment are going to be next time the Mets assert themselves. But in a nutshell,
it's an incredible and inspirational story. I mean, I love hearing it every time I talk with you, Ken. I mean, you and patients like you, they're the reasons that we go into oncology, and that we're trying to sort of change that trajectory, of bladder cancer. I think one of the things that you particularly have experience in is clinical trial participation at different stages of your disease. So you mentioned that after your initial surgery, because of sort of the pathology that you had that predicted there was a high risk of it coming back, that you went on an initial study that had 2 arms on it. And one of the arms, got the vaccine at that time designed against the cancer, and the other was standard of care, which was observation at that time. And then later on, when your cancer recurred, you went on an early phase 1 study where everybody got the drug, but the drug was a little less proven at that time. And I wonder if you could maybe walk us through a little bit about your thoughts as a patient at those different stages. So, the first one, when there were 2 arms, but there was no disease back and we were trying to prevent disease from coming back, versus a little later in the game when it did come back, and how you felt about sort of randomized trials versus kind of earlier stage phase 1 or single arm type of studies.
I understood the chances that I'd be possibly randomized into the control arm. Having a background as a patent lawyer, I was not afraid to get into the literature and to read. And my blog that I was creating and keeping up, I was processing a lot of the options and understanding at the time. It seems like the dark ages of bladder cancer, when the odds for surviving for 5 years with metastatic disease were less than 5%. And the doctors, the clinicians I consulted with, Gary Steinberg, Andrea Apollo, and another oncologist with GW, all agreed that this was probably the best thing I could do was see if the dendritic research would have any benefit, and if nothing else, even if I was in the control arm, it would get me in touch with more doctors. And my view was more is better than fewer. And sorry, my dog is barking in the background. But
okay.
so I was comfortable with entering that trial when I knew I didn't have any active disease and I was in a watchful waiting stage. The second time, actually, when I was being screened for a second trial, is when it found the pulmonary embolisms. And I didn't go into that trial, obviously, because I had to knock down the PE first. But for being screened for that trial, I probably wouldn't have had those pulmonary embolisms located and treated. So that was simply an opportunistic benefit that was a consequence of my exploring the clinical trial universe. And then, of course, the third one was with you, Noah, and getting into the initial stage 1 for immunotherapy. At that time, my tumors were growing at almost a centimeter a month up and down my neck, and the whole side of my left side of my neck looked like I was on some sort of a steroid of just being bulged out.
Yeah.
They were starting to impact on my carotid artery. I knew only a few weeks to live in all likelihood, but I was told, this immunotherapy is going to be your best shot at having something done. So I was all for it. And I was grateful for Dr. Apollo and for Hopkins and yourself for letting me get into that trial, because I think at the time, Hopkins hadn't even opened it up to bladder cancer patients. I was kind of the first one to knock on that door.
Yeah, I think you're right. Again, because that was 2014 and they had just started enrolling specific disease cohorts, and you were one of the very first. Speak to a little bit about, sometimes kind of fears, anxieties from patients' perspectives about being in clinical trials. You mentioned especially the trial that you went on with nivolumab that wound up, turning the course on your cancer. Again, many of us now in 2021, it's only been 7 years since those studies started. And, we take for granted that we are seeing patients who are doing better with these therapies, but take us back to that time again, where we had a hint, that these drugs worked for some cancer types that had very advanced disease. And there was a reason that we shifted towards bladder, and we felt that there might be a chance there as well. But we didn't know. And, as you're seeing and hearing your cancer growing, on the scans and reports, just the steps of, getting into a clinical trial, and speak to that about, to our audience about, I think all of our patients, when we talk to them about clinical trials, when they want to participate, they want to start now. All right, let's get it going. I'll sign. Let's go. Let's get it started tomorrow. And walk through some of the logistics of what does it actually take to actually get, quote, into the study. And how did that weigh on you and your family in terms of sort of the ups and downs, anxiety about the disease and just the of participation?
I had the great benefit of meeting Andrea Apollo at a BCAN presentation back in early 2012 when I was just starting my first round of chemotherapy. And she, for those people who don't know Dr. Apollo, she directs bladder cancer research at the NIH mothership in Bethesda. And she immediately said, come on in, let's talk, let's look at what your options are. And she continues to have the view that once you are a patient at NIH, you are a patient for life, and continues to follow to this day my case. I also understood that with the seriousness of my disease, that I wanted to know what all my treatment options were going to be. And so I had the good fortune of making her acquaintance, and she has knocked on a lot of those doors and done a lot of the legwork for me in getting others in the community to do that. And I have always been one to follow the science and to want to advance where I can and do my part as I can. So I had very little hesitation in speaking to those who are on the leading edge of research. And after it was found that I had metastatic disease, the question was going to be, well, what can I do both to increase my chances and help the community? So that's how I was able to make the community, make the connections, and have those doors open. Yeah, there's a lot of paperwork. And for example, when I was in your trial, Noah, it seemed every other time I'd come in, I'd have to sign a new protocol because it was, from phase 1 to a phase 2 to a phase 3, and going through 40 pages of documents and understanding whatever new risks were being disclosed. And again, I was absolutely comfortable with that, but I understand that clinical trial research isn't possible without killing a forest. So there continues to be that burden on the disclosure and the documentation. And an advantage that I have now being on the Bladder Cancer Task Force, I see the new trials that are being proposed and the new research that's coming out. I keep a constantly evolving list of what my next therapies are going to be, or what they may be based on when my tumors are going to reassert themselves. And to see how quickly moving the available therapeutic options are. When I started this journey, there was no immunotherapy available. There are now 5 different types of immunotherapy, and now there are 3 or 4 different types of targeted immunotherapies, and so many emerging combination therapies that what might be available this month is going to be different 3 or 6 months from now. So that to me tells the whole community, get into the clinical trials research, because that way you're going to have access to the latest available therapies, especially if you have advanced disease.
Yeah, you have a very unique perspective, both through your experience in clinical trials, but also your participation with the research organizations like BCAN and the task force and the steering committees. What would your advice be to patients and families out there about sources of information, but how do they form sort of their own team or get information about clinical trials? Because it can be a little overwhelming. What are some good places or resources that you've found to be very patient friendly, and how do you advise patients when they contact you?
Yeah, and I'm in contact with patients on a weekly basis, and I point people to BCAN's website, bcan.org, and under research, there is a tab with clinical trials that is continually updated with bladder cancer clinical trials. And that's a very user-friendly resource. The PDQ for patients at cancer.org for, I read the physician side because I want to know all the additional details, but the cancer-facing side, the patient-facing side is an outstanding summary of what the current research and data are. Being proactive as a patient and asking your oncologist, who would you go to if this was you? What, if you're not at an NIH center, go to an NIH center and get in with the patients or with the doctors who are following the latest research. You know, make sure your doctor is going to ASCO and keeping current on what all the latest research is. Be proactive as a patient. Nobody knows you better than yourself. And don't be afraid to ask the tough questions. Write down your questions in advance and don't leave your clinician's office until they're answered.
Yeah, I really like your theme about being proactive, you know, as a patient, caregiver, and even provider. You know, you have had different medical experiences and even trial participation at different medical centers. Some of that correlated to where you were living at the time, but also you sought them out. Can you speak to a little bit to the patient side about that process of looking at other centers from where they are being treated as options or resources for clinical trials, and you know, how they should feel about that, how that process works? And then I can speak to a little bit out from the physician side, because I think sometimes there's a fear or hesitancy sometimes to reach out.
Yeah, I think first of all, it's a willingness on the patient's part to be proactive and not listen solely to the urologist who first told you you had cancer. For people who are out there in the community, in the clinics, know that there are resources out there. Know where your nearest NCI center is. And you can initiate contact with them and seek second opinions of your pathology, of your transurethral dissection. I mean, my initial pathology was done through Hopkins. I sought out second opinions at GW, and then the second opinions were the Hopkins pathologist, and they're the ones who diagnosed it as micropapillary, because that occurs in only about 2% of the cases. Now that happens to be, and that was before there was good data on genetic predictions, and knowing how aggressive micropapillary is, that affected my treatment decisions and told me I wanted to be aggressive and have neoadjuvant chemotherapy, and also understood that there was a good chance I was going to have a radical cystectomy. I consulted, I put in a blind phone call to Bill Shipley up at UMass, who is one of the fathers of bladder preservation. I got his name from my first meeting and consult at Hopkins. He spent an hour on the phone with me talking about what my options were, and at the end of that call, I understood there was no way I was going to keep my bladder. But talk about a helpful researcher who I met him in person 6 years later. He didn't remember my phone call, but tremendously influential to me. And that was only because I asked questions at my first Hopkins visit. Who should I be talking to if I was interested in knowing more about bladder preservation?
Yeah, I think that's a great example of reaching out to people across the country and nowadays across the world. I mean, I think there are a lot of resources, people who do respond. I think from the physician side, I think it's important for patients and families to know and understand that the majority of us do not take it personally if patients are looking at other centers for other studies. In fact, we encourage it. The simple fact is that we all at our medical centers have clinical trials. We may not have the exact same menu at each center, and that may be decided by different research directions, but some of it is just timing. Trials open at different time points throughout the year over the years, and sometimes we're in the midst of one study at our center. We try not to have 4 studies for the exact same population going at the same time. So there may be a better fit sometimes at another center. And particularly, East Coast, West Coast, and other places where there are a lot of medical centers fairly close in driving distance or train right away. That's kind of normal for the course. So you'd mentioned, Dr. Apollo, Dr. Shipley up in Boston, Dr. Rosenberg, Bajor, and others up in New York. We have patients who go back and forth fairly frequently. And I would say in the bladder cancer community, for the most part, we're all pretty good friends and colleagues, and we want to see patients do well. So if we see a patient have success who goes on to a study at another center, it makes us happy. That's what we're in it for. So definitely don't want patients or families to feel somehow that there is some tension there from their treating physician. That shouldn't be part of the equation at all. And I also, Ken, what you said about reaching out, for instance, to Dr. Shipley, I would not discourage patients, again, in a technology world we live in now with, social media, email, and all sorts of things. It can be a little exhausting, but there are plenty of world's experts who, if you do reach out to them, they may not get back to you in 5 minutes just due to the volume of communications, but there are many who will get back to you. And they may not be able to help you specifically right there, or they may be able to filter through and decide, do you really need to come and travel of a long distance to see something at their center? What's more important is they may be able to tell you what's right in your back door, or be able to reaffirm some of the experts that are very close to you. That is sometimes hard to tell. So I think that's just something from the physician side that I would kind of want to get out there as well.
From a patient standpoint, I think the most critical thing is accepting that you want to have a voice in your treatment decisions. There are some cancer patients and bladder cancer patients who don't want to know anything about the details or what's going on. They simply want to follow what their doctor says, and the stress of knowing that is too much for them. I get that. But I also believe that there are patients who understand that in a fast-moving environment that we're in right now, where cancer therapies are changing month to month, that what was true 2 years ago is not true today. And the therapy that was available 5 years ago there might be a much better therapy today, that patients who are willing to be aggressive in taking the lead of their treatment decisions and asking those questions have a significantly better chance of successfully managing their disease and having a better prognosis.
Yep. Couldn't say it better. So I think in the interest of time, we're going to move over to some questions. As we're kind of going through the chat, I just wanted to have one final question for you, Ken, about clinical trials. Again, as a patient who's gone through multiple different times and over the years, what excites you the most about clinical trials in bladder cancer today compared to where you were when you first started? And then we'll leave that as a segue to the question and answer.
When I first started, chemotherapy was the only game in town for metastatic disease. And so I had 2 different types of chemotherapy. I still have peripheral neuropathy in my feet from the dose-dense MVAC for the side effects. But the name of the game was playing cancer whack-a-mole, was beating the disease down, keeping me alive until a better therapy came along. I understood that then, and today it's no different. Only we have therapies that have fewer adverse side effects for the most case. And to have the game changer of immunotherapy and then having the new therapies and the combination therapies that are out there, that some of them are having a success rate of a complete response rate of better than 80%, which is, to me, that is just tremendously exciting news. And I don't think we're at the stage yet where we can use that non-medical four-letter word of cure, but I'm happy with having a complete response with no evidence of disease while continuing. I have had 49 CT scans in my career, and I'm going to have them every 12 weeks for the rest of my life. I get that. But when the next shoe drops for the next time it shows metastatic activity, well, I'll see what the best treatment is at that time, because it wasn't the treatment that was out there 3 years ago or even 2 years ago. There are some exciting things going on. So I can transition into Q&A.
Well, thanks, Ken. David, did you want to kind of go through, I know there's some things in the chat there, as well as some questions you may be getting offline.
I think that, to start with, one of the constant challenges is navigating all the choices and how to get yourself the information you need to make good choices. So Ken's right. We've got a lot more options than we did 5 or 10 years ago, certainly. How would you recommend people do that, Ken? Now, you took a fairly sophisticated approach yourself, but what would you suggest to everyone about what you've learned about it?
My brother-in-law was just diagnosed with bladder cancer 2 weeks ago through cytology. He's waiting for his first transurethral bisection, which will lead to a staging. And at that time, he'll be looking at what his treatment options are, whether he's going to have BCG or whether he's going to have something else. And I've gone back to the clinical trial database to educate myself on what the current options are for non-muscle invasive bladder cancer, if that's in fact what he ends up having. And we don't know if it's going to be low grade or high grade. So I'm going through this process on behalf of my brother-in-law as if it was somebody who was newly diagnosed. I'm happy to be comfortable with sifting through that process. But to those who are newly diagnosed and feel like they're still drinking from the fire hose, look to your clinician first. Look to and ask her or him what the available treatment options are, both from the standard of care as well as understanding what emerging therapies there may be out there, and asking for an honest assessment of what the data can show. Follow the science. Don't listen to my mom, who was trying to push broccoli smoothies and standing on my head and holding crystals in each of my hands, or whatever other things might be out there. But look at what the data are, and depending on what your staging is, the best thing may very well be following the standard of care, but it's also appropriate to understand that there are emerging therapies that might be the right option for you.
Yeah, so if I'm just diagnosed with cancer, I can imagine that my anxiety's through the roof, and I'm living in my amygdala, part of my flight or fight response. Are you kind of suggesting that you get somebody to help you kind of navigate that process, whether it's your partner or a loved one or somebody who's invested?
Well, having a caregiver is critically important. And hopefully it's somebody who is there close to you and can help you sift through that data and sit with you and hold your hand, take notes while you're meeting with your clinician. I, with my clinician's advice, recorded many of my early visits so I could go back and listen to them later on while trying to understand what my options were. Reaching out to the bladder cancer community through BCAN or through Inspire, and having somebody, I review my contacts weekly through BCAN and Inspire to have somebody able to help you navigate that fear that comes with that initial diagnosis. BCAN has a wonderful section on newly diagnosed and help and forms a framework that new patients can sift through in understanding where they're at, because what your staging is drives the questions you ask into your treatment decisions, and being able to understand that is vitally important.
So Noah, as somebody who sets the national agenda in collaboration with people like Ken, what about your insights into how to find these clinical trials? Of course, Beacon is a fantastic source of information, but if you have any other suggestions about how to do this.
Yeah, I mean, I think I would kind of point out sort of two things. I mean, one is, I think your treating physician team at your local, geography of where you're at. They are your advocate. And, I think I am a strong believer that I think it's healthy for people to get, second opinions at the time points when they're thinking about changes in treatment care. Not so much change in a physician, but if they're having to make a decision now about surgery or radiation, or they're needing to decide about a specific type of therapy for their disease that has come back. We would never go out and, buy a house with only looking at one house. Maybe there's some people, but not many, And I think that those second opinions can be incredibly helpful, even if they do nothing other than reaffirm the opinion that you've gotten already or the trial options that you have locally. Because, this is real people. It's not buying a car. And there is a lot of anxiety and emotion and things that go into this that I think can affect ultimately our ability to deliver the best care. And I think everything that we can do to put patients and families into a position where they understand the plan, understand the alternatives, feel confident about the choice that they've made, and can move forward in sort of an engaged fashion with their healthcare team, I think is really helpful. So I think second opinions and things and that's so forth, I think are really helpful. We do it frequently, and I don't think any of us have any problem or issue with it. Secondly, I think from a resource standpoint, Ken and David had mentioned the Bladder Cancer Advocacy Network. It's a great source. I think also, again, to let the audience know here, we at the GBCI also want to be a resource for patients and their families. So the more the merrier, I say, when you're in the fact sort of finding stage. So if people have any questions about their disease and their process, we're happy to try to help them and assist them in that journey. I think it's important for patients and families to understand that we are in a virtual environment. And so there are some issues sometimes with healthcare information and personal information. And so there is a limit to the extent that we can sometimes do sort of virtually by communications without setting up a formal visit. And some of those formal visits can be virtual. Many of our colleagues do that. I find for myself, for instance, that bladder cancer patients often are very complex in terms of their other medical issues and other things that are going on, and that our therapies are sometimes very complex, that when it comes down to actually making treatment recommendations, actually saying, this is what I recommend for your treatment, I personally prefer to see patients in person at least once. But there are many things we can do virtually to still help patients in their journey. So I think, reaching out to every resource that's there is what I would advise folks to do.
So, it's become obvious.
One of the first opportunities, sorry, David.
No, go ahead.
Go ahead. One of the first opportunities for many patients to seek a second opinion is with pathology. After the initial TURBT has been completed, to have those slides sent to an NCI center. And virtually every NCI center, including Hopkins, allows for the pathology to receive the slides, read them, and return a reading very quickly. And it doesn't require you or any patient to go there. You just arrange to have the slides FedExed up to Hopkins, and then in less than a week, you're going to get the results. And that helped me understand, as I mentioned before, that I had micropapillary. Everybody who's diagnosed will almost always have a TUR and have tissue available for that reading. So that's one of the first and least scary types of second opinions that you can go to. But I think Noah's standpoint of saying, who would have their house renovated or put poison into their bladder with just one opinion? Second opinions are great to have. And if your initial doctor doesn't want you to have a second opinion, then get one. But first of all, support it.
So the sources of information that we have now are complicated. We see now, even with the COVID pandemic, that there are all kinds of different things being said online. I can imagine the same is true with the information that's coming at us about options for therapy. So I've heard, Ken, you mentioned NCI designated cancer centers, and certainly we are part of one here, and we work with a lot of people who are involved with them. If you're at a local facility, if you've got a community practice urologist, for example, how do you connect with the comprehensive cancer centers, and is that really necessary?
I believe it's necessary because that's what I did, and I'm alive after 10 years. And I draw a line between my disease management and the team of experts that I've put together. Were it not for my proactive in seeking out care at NCI centers, I don't think I would be alive now. So to me, that is a good enough reason to recommend that other people do that too. There are, through any kind of basic internet search, you can find out your nearest NCI center close to you, and all of them have excellent websites. And if you don't want to do that, send David or Noah an email, and they'll hook you up.
That's absolutely true. Noah, what do you think about that? Do you think going to a designated comprehensive cancer center is important?
Yeah, I do. I don't know exactly about the comprehensive status, because that's kind of changing a little bit, and there's only so many. But I think NCI designated for sure. There have been many studies that have been done that have talked about, for instance, the surgical aspect of bladder cancer and other cancers, that it does depend on volume, and that centers and individual physicians need to be doing a certain amount to become experts in it, not only to make sure that we're delivering on the best chance to hopefully cure bladder cancer and upper tract urothelial cancer, but also to try to minimize complications. As many of our patients and families know, these are big surgeries, and you want to be in centers that are prepared for complications that can happen. So absolutely, I think getting an opinion at an NCI designated cancer center is critical. And I think that most of our cancer centers are pretty adept and pretty familiar with being able to sort of decide and work with our community physicians to try to deliver as much of the care as we can close to home. So for the types of care that would be the exact same that we would be delivering, at Johns Hopkins, that can be delivered at our community oncology or other practices, we work with those local physicians and teams to make sure that they're delivered in a timely and effective manner. There are some types of, and some aspects of the care that we're just fortunate to have some deeper teams with expertise that it's the only thing that they do. And that's why we exist, is to be able to provide that. So I think it's a team approach.
I think it's
it's never an issue of trying to bring patients in and keep them or take away. It's about working with the entire physician team.
Just a quick thought on that. My chemotherapy was developed by recommendations from both my local oncologist and NCI doctors. I received it as close to home as I could, even though it had been recommended by NCI doctors. I didn't have to go up to Baltimore each time to get my chemo. Likewise, my initial involvement in the nivolumab trial was going up to Baltimore each time. But then I moved out to Utah, and one of your proteges, Ben Mon, came out to University of Utah. I waited to transfer my care until he arrived and set up. But he was the one who was doing my next round of nivolumab after, and that was with ongoing consultation with you. And I know Ben still talks with you about my case, and wonders how much longer my beard is going to grow. And I'm happy at that. To me, the more doctors involvement, the better. So every time, as David said, when there's a treatment decision to be made, getting involvement with as many professionals as possible, figuring out what the treatment is, and then going to the most convenient place who can deliver that therapy.
Yep.
Got kind of closing.
We got a question, I think, from the chat. One and one to Ken. The one to me from Stephanie Greenberg is, what happens when, like Ken, there's a robust response to the clinical trial treatment? Is there a decision made to stop the trial? Do trials have endpoints, or is it possible to still receive the drug once a patient is, quote, off trial? It's a great question. I think every clinical trial is a little bit different in terms of the recipe of the drug treatment, in terms of how long they will treat. Many studies, if they are for patients who have disease that is growing after they've already received most standard therapies for their cancer, many therapies will treat until one of two things happens. The cancer grows on the new study therapy, or if a patient is having side effects from the treatment that we feel is putting them at risk for harm, we would stop. And many studies don't have an endpoint. In other words, if a patient's benefiting, they'll continue to treat and treat and treat because they want to know how long that response lasts. That's not true, however, with all studies. And Ken, I can't remember on the phase 1 when we did this, but I know many of, for instance, the immune checkpoint inhibitor studies, many of them put a limit of 2 years on some of these particular therapies. Now, sometimes when a study says there's 2 years benefit, if we really do see patients who are benefiting beyond 2 years, the company may actually write what's called an extension protocol. It's technically a separate study, but it's basically for patients to kind of, quote, roll over from one study to the other to continue receiving the drug that they are benefiting from, but not always. Can they get the drug off of trial? Well, if they're in a drug that was so successful that ultimately results in FDA approval of the drug for their disease, and the short answer is yes. And that's happened for some of our patients in the immune therapy clinical trials. Ken, I think there's a question there also from Stephanie about sort of decoding some of the language in clinical trials and some tips for those considering studies.
Yeah, on a response, no, I was in the stage 1 that turned into a phase 1 to a phase 2 trial. And there was no discrete endpoint, although at 22 months, I had a complete response by then for 16 months. And you looked at me and said, and I was having some dermal toxicity, rash around my torso and my calves. And you looked at me and said, I don't see why you should stay on this. It's done what it's going to do to you. Start doing your watchful waiting thing again. So I went off treatment after, 60 plus rounds of immunotherapy. But that was something that you and I decided without having a discrete endpoint because there wasn't enough data on that. And then in the interim, nivolumab had received approval. So by the time my tumors came back, I could just go back into you and say, okay, what do we do now? And you said, well, let's go back to single agent immunotherapy. It worked once. Let's see if it works again. And it took a little bit longer, but it worked. And that was because the drug had been approved. In answer to Stephanie's second question, how to decode, BCAN works. And I remember I took printouts of a dozen different trials to Andrea Apollo after I came back from my surgery in the summer of 2012 and said, what do I do? And we went through all of them. And she's the one who, helped me decide that, trying the Dendreon trial was probably the most sensible thing at the time.
Yeah, it's a shame that we don't have a Google Translate that recognizes clinical trial as a language, because it can be very, very tough, even though most of our IRBs say that these consents and things should be written in 7th or 8th grade language. When I read through them, and I sat on our IRB, it's still very complicated language and logistics and volume of information. When these consents, like you said, are 30, 40 pages, that becomes a book, Yeah, so.
I had fun catching some of the mistakes in some of your IRBs that I point out and you do the head slap and say, oh, geez, we got to do these again. But I'm strange that way. That's my lawyer hat going on. And but I don't know if Dave, there are any more questions?
I think we've come to a good time to close. Also, because I got to jump on the Southwest Oncology Group meeting next. So it's great meeting with you guys again. Great to have all of you come and attend this, and look forward to seeing you again next time.
Thank you for hosting.
Take care.
Likewise. Thanks for having us.
Yeah, bye.